So part 2 of trauma, we're going to talk a little bit about trauma assessment. Now, I've talked about in part 1 tunnel vision, okay? So please keep that in mind. Keep a big picture, you know. So, but where does trauma care really start? The people on scene, right, who are trying to do their best to help people, and you know, sometimes those people are educated folk as far as medicine goes. I mean, I've wandered up to the scene to help out at an accident, and you know, one of my local anesthesiologists was standing there on scene first, who worked in the ER also, you know. And so sometimes you get some good help and some bystanders who know something, much less all the EMS folks, okay? But it starts with the call taker, and they have to recognize that there's something going on, that it's not just another typical fender bender, you know. Our first responders, whether it be police, fire, bystanders, and then of course us. Now, EMT 101 says that for trauma patients, you have to do a primary assessment and a secondary assessment. And I have done intercepts for a long time all over the state of New Hampshire. And one of the things, not just intercepts, but also primary response in areas that have first responders, you know, because we're in one town going to another town. But one of the things that I've seen across the board is kind of a lack of a coordinated assessment by a lot of people. I mean, I've gone into houses and they can't tell me, you know, the first responders, and these are EMTs, AEMTs, and in some cases we're paramedics. They can't tell me the history of the present illness. They can't tell me lung sounds. They haven't done an EKG, but they get the clipboard in their hand and they're writing name, date, demographics, all that crap. No, do an assessment, for the love of Christ, please do an assessment, okay? So primary assessment, what I like to tell people is that is what's going to kill somebody in the next minute or two. And the secondary assessment is what's going to kill them in the next 5 to 10 minutes. Right? So ABCs, this is what we've been taught forever. I took my EMT course in 1985. I was taught ABCs. I was taught you cannot go past A until you fix A, right? You have to fix A before you go to B. You have to fix B before you go to C. There are some new schools of thought out there about this, though. Okay, so let's talk about this. Our ABCDE. Let's add to this. I was taught ABCD. And it was airway. You know, is the airway open? Will it stay open? This is how I make it. This is how I teach it. Let's keep it simple. Is the airway open? Yes or no? Will it stay open? Yes or no? If the answer is yes to both of those, great. I don't have to worry about it. But if the answer is no to either of them, do something. Is the airway open? No. Fix it. Is the airway open? Yes. But no, I don't think it'll stay open. Throw a nasal airway in them then. Okay, have somebody committed to the head doing an airway maneuver and watching that airway, okay? Then breathing, are they breathing? Yes or no? Is it effective? Yes or no? Will they stay breathing? Yes or no, okay? Excuse me. Circulation, right? Do they have a pulse? Yes or no? Is it adequate? Yes or no? Now, disability is neuro, right? Check your pupils. Can they move things? And then expose an environment. I see a lot of trauma patients fully clothed. I can think of a motorcycle accident where AEMT on scene and his EMT partner with other AEMTs and EMTs on scene from that first response service. Patients collared and collared in the back of a truck with jacket, 2 sweatshirts, and a vest on, with a wrist splinted, getting an IV in one hand, and they don't have vitals for me. And patient's fully clothed. and they haven't pushed on his belly. They haven't listened to lung sounds because I got to get the IV. No, you don't. No, you don't. Do your primary and secondary assessment, okay? Well, I couldn't get his jacket off. He's lying down. But when you got here, he was standing up talking to people next to his motorcycle. Get his coats and shirts and jackets off him. He didn't want a scut leather jacket. I get it. Take the damn jacket off, okay? Get them exposed. But keep in mind, environment, you got to keep them warm. Now, as I said, airway, and it's BLS first. This is one of the things I see medics and ER docs fail at. I got to intubate the patient. How about you do a jaw thrust first? How about we just lift the tongue out of the way and so they're not snoring? How about we suction them first, okay? BLS first, then we can go to ALS if we need to. Now, can we move on before this is fixed? Let's talk about that in a minute. Breathing, yes or no, adequate or inadequate? Now, as far as oxygen, we know with chest pain and strokes and all the American Heart Association stuff, as long as it's 95 or above, they don't need oxygen. This is not cardiac care. Trauma patients need oxygen. If their SATs are at all questionable, if you are worried at all about multi-trauma injury, they need high flow O2, okay? Because you got to think with breathing, what affects breathing? Oh, pneumos, hemos, contusions, oh my, right? Rib fractures, just for the fact that their ribs hurt, they will not take a deep breath. They have crappy tidal volume, they become hypoxic, much less the fact that they've got paradoxical motions with a flail chest, okay? And if you see one of these things, fix it. They got a hole in their chest, put your gloved hand on it while somebody else gets you a chest seal, okay? If they have a flail segment, start bagging them. Start assisting respirations, okay? And then we look at circulation, hemorrhage control, all right? It used to be, is their airway open? Are they breathing? Do they have a pulse? And then, I'll worry about bleeding afterwards. No, under circulation, do they have something that's, going to kill them? What are their perfusion signs? If you look at the National Registry trauma assessment paper, it's under the primary assessment, skin temperature, moisture, condition, because that tells you perfusion, right? If they're perfusing their skin, they are not shunting. They are not trying to compensate for shock, okay? Do they have decent pulses? Do they have, and this is Goldilocks and the Three Bears. Is it too fast? Is it too slow? Or is it just right? Okay, I'm not taking 15, 30, or 60 seconds to count a pulse right now. I just want to know, hey, it's strong, it's regular, and rate-wise, I'm happy with it. It's good mentation, which tells you perfusion. And cap refill, more than 2, less than 2. Disability, their mental status, their mentation, and what's their neurological status? Can they feel you touch them? Can they wiggle toes? Do they have intact pupil actions, okay? And then the exposed environment, yeah, we do want to strip all trauma patients, but yes, they do die if they get cold. When you look at hypothermia from just a strictly environmental aspect, right? Grandma walks away from the nursing home and it's 30 degrees out. If grandma drops her temperature to 90 degrees, her mortality rate is about 20%, okay? So you warm grandma up fairly quickly and fairly safely, she's gonna do okay. You have a trauma patient who hits 90-degree body temperature, their mortality rate is 100%. So we need to keep them warm, but we're gonna strip them. Yeah, we are, but you can get heat blankets. The other thing I might do, it's 5 degrees out, I'm at a snowmobile accident, I might cut up the center of their, clothing. I might unzip their coat, cut up the center, visualize the belly, visualize the chest, palpate both, and then fold it back over them until I get in the truck. As soon as I'm in the truck, boy, I get that heat cranked all the way, and I'm cutting their clothes off, and I'm getting the clothes out from underneath them because the clothes are wet and the clothes are cold, okay? So if ABC is the standard that we've been trained on, if we do something different, won't we get in trouble? In other words, well, he's got a laceration to his left thigh, and it looks like ooh, he's bleeding pretty bad, but he's snoring. I need to fix his snoring. Well, what's going to kill him first? You know, my wife without CPAP would snore all night. The loudest snoring you can imagine all night. You know what? She'll wake up in the morning, 6, 7, 8, 9 hours later. So if this dude is lying on the ground with snoring respirations and he's bleeding out of his femoral artery, which is going to kill him first? The femoral artery is. But if we don't follow what we've been taught, won't we get in trouble? Well, I think back to my EMT practical in 1985, and as I walked up to the trauma patient assessment station, I said, hey, BSI is seeing safety. Do I see any obvious signs of bleeding? Yes, under his right leg. I'm having my partner take care of that. And then I went to ABCs. Okay. Now, recently in the last 5 or 6 years in our textbooks, we're seeing some options. One is XABC, exsanguating hemorrhage. So this is hemorrhage that will kill you. I'm not talking a slow little bit of pooling from a couple of, a small vein. I'm talking large pools of blood. I'm talking squirting, arterial bleeding, things like that, okay? Then your airway, then your breathing, then your circulation. If they're not breathing and they're bleeding out of a leg, you got to start bagging them, right? What's going to kill them first? Now, the military, some point 10, 12 years ago, started talking about the mnemonic march. The Ides of March are upon us, right? So March, massive hemorrhage. Now, mind you, this is a Civil War reenactment. This is pretty good, but they've got a tourniquet on above the site of the amputation they're doing. Massive hemorrhage. Airway. They are teaching military folks of all branches, your basic infantrymen, your basic cook, whatever, that to use tourniquets and to put nasal airways in, because nasal airways save lives, and it's quick and it's easy. Do a head tilt, chin lift, throw a nasal airway in, you keep the airway open. Respirations, right? Are they breathing? Do they have things that will alter their respiratory system? You've got a hole in your chest. You've got to cover it. Otherwise, you're going to develop a tension pneumo. Now, this hole is moulage from a Homeland Defense drill that they did. This is some of the best moulage I've ever seen. And we don't do a good job at this. We did a school shooting drill when I was with Exeter Hospital as an EMS educator. I did this drill with Nottingham Fire. And one of the patients was my high school age son, and he had moulage on his chest and his back for an entry and exit wound. He had an index card that listed what his injuries were. The people who triaged him did not address the hole on his back. The treatment center folks did not address the hole on his back. And the paramedic in the transporting ambulance that had 2 patients did not address the hole on his back. We don't do a very good job with this, okay? Circulation. Hey, tourniquets and hemostatic dressings, hemostatic powders. And then hypothermia. Keep them warm. Now, bottom left, this Ready Heat 2, these things are great. I saw these first at Frisbee probably 12 or 13 years ago, 15 years ago even. Action EMS here in New Hampshire just bought them as well. And I've been preaching them ever since in between, okay? These are those little hand warmers that you see, like hunters and hikers and fishermen carry. But I think there's 27 of them in this blanket that will cover from your ankles up to your neck. You rip it out of the bag that it comes in, the sealed bag. You shake it to get some air into that powder in those little pockets of chemical, and it heats up. It takes 5 to 10 minutes to heat up to 105 degrees. You strip your trauma patient, you put a sheet on them, then you put this down on the sheet, and then you put blankets over the top of them, okay? I used one once. A guy came down off a ladder and shattered his ankle and tib fib, and would not let us move him until I drugged him. Literally, he was panicked from the pain. And so and it was cold fall day. We ripped one of these open, wrapped it around him, threw an IV in him, knocked him out, and then splinted him and moved him. They're great devices, okay? Turn the heat up in your ambulance, right? The thermostat, the thermometer that you can see. Problem is, some of these ambulances I've been in recently, you can only turn the heat up to 80. Most of them, you can only go up to 90. I've been in one ambulance that I can think of where you could set the thermometer at 100. Set it at 100, right? 98-degree body temperature. You know, most of the time we're in, you know, let's say it's August and it's 95 degrees out. We're sweating our asses off while we're taking care of this guy. We put him in the back of the truck stripped naked, and the first thing we do is crank the AC down because we're sweating our backsides off. You got to turn the heat up, okay? As bad as that sucks. IV fluids, IV warmers, absolutely. We should not be putting a ton of fluid into our trauma patients anymore. Permissive hypotension, okay? Look that up. But warm IV fluids, wool blankets, electric blankets would be great. But most people don't want to be dropping 50, 60, 70 bucks on an electric blanket to turn around and throw it away, single use after every patient. So which one do you like better? A, B, C, D, E, right? Airway, breathing, circulation, disability, exposed environment, exsanguinating hemorrhage, airway, breathing, circulation, massive hemorrhage, airway, respiration, circulation, hypothermia. I like March. And you can find this in books. You can find this in PHTLS. You can find it in the military version of PHTLS. You can find it in the military medics training manuals. EMT 101 now. What's going to kill them first? Fix that. And we're very rarely alone. You know, if it's you and your partner and you've got a patient who's snoring and a patient who needs a tourniquet, hey, dude, you take the airway, I'll throw the tourniquet on, okay? All right, so patient assessment. I feel that's a huge piece of this. I think it's a travesty to not spend 20 or 30 minutes talking about assessment and refreshing you on your assessment thoughts and skills, because I see a lot of very, very crappy patient assessments from all levels of care, EMT, AEMT, paramedics, nurses, and physicians, okay? Trauma assessment sucks in a lot of the country, okay? So anyways, use that 30 minutes for personal time, okay? As opposed to trying to plug it into these hour and a half for your NCCP national hours. All right, so let's continue on with part 3 here in a minute.